Hi, this is Pat McDonald, your host for Vote for Vermont, where our tagline is listening beyond the sound bites. To my left is Ben Kinsley, who is co-producer, you have so many titles, co-producer and sponsor. Could you tell a little bit about your adventures?
Your
adventures.
I don't know about my adventures, but I am the principal, the principal of Imperium Advisors. That's a consulting firm. We do a lot of work with public policy development and advocacy work with nonprofits, sometimes political campaigns, and of course, trying to get folks organized. So, yeah.
That was a really good one. You've been practicing, huh?
I need to practice some more.
He is so good on policy. He's really great. And my special guest, our special guest tonight is Kevin Mullin, who is the chair of the Green Mountain Care Board. Kevin, welcome to the show.
Well, thank you, Pat. It's a pleasure to be here.
Yeah.
Ben?
Thanks so much.
Yeah. It's been a while.
It has.
No stories. That's one of the deals we make here. I won't tell about you. You don't tell about me. So,
I'll try to hold up to that.
It'll be difficult. Been floating around Montpelier long enough.
Yeah, well, we've been in the legislature together.
Yeah.
Anyway, but first we ask our guests to tell a little bit about themselves, their background, and maybe how you came to be the chair of the Green Mountain Care Board.
Okay.
And why.
It was kind of a circuitous route that took me to the chair of the Green Mountain Care Board. I'm a native Vermonter. I grew up in Rutland. I went to Castleton University, got a degree in finance. And most of my life was spent in small businesses. I owned movie theaters, had a couple of video stores. At one point, I owned a company that distributed Vermont-made food products and did the Vermont sets in the stores.
Wow.
And in '98, I was a little bit frustrated as a school board member in Rutland Town. If you remember, that was when the first version of Act 60 was passed.
Yep.
And we were considered a gold town, and we had made conscious efforts to try to be the absolute best school, and all of a sudden we were hit pretty hard for it.
Yep.
And so I ran for the House, and in '99 was the first year that I started, election of '98.
Yeah.
And I remember you meet with the speaker and you fill out a form, and they ask you to fill out your 3 top choices for committees.
Right.
And so I had a real good conversation with Mike Obahowski, who was speaker at the time, and I thought for sure that I would get something that I asked for. And I had been appointed to the State Transportation Board, so I was on that. So I put down transportation, knowing that was a little bit of a stretch for a freshman.
Right.
Same thing with the Ways and Means Committee, because I had a degree in finance. I knew that was a stretch. But the other 2 committees that I put down for, one was Commerce. I was the chair of the Legislative Issues Committee for the Rutland Region Chamber of Commerce. And the other one was Education. And I thought as a school board member, I would probably get either Commerce or Education. So much to my surprise, Speaker Obahowski was reading off the roles of the committees, and he said Health and Welfare, and then he read a couple names, and then he said Mullin from Rutland Town, and I'm like, wow, what did I do to Mike? I thought we had a great conversation, but come to find out, that was the year that we were looking to do welfare reform.
Oh.
And so they were looking to put some people that were familiar with numbers on the committee.
Right,
so
for sure.
Malcolm Severance, the former dean of the business school at UVM, was put on the committee. Dave Hathaway, he thought it was kind of a little bit of a slap at him because he had been on Ways and Means, but he voted against Act 60, so they moved him off of there. And
that's how it works behind the scenes, right?
But we had some pretty good members of that committee, and learned a lot. Tom Koch was a member of the committee.
Can't beat Tom.
Yeah, and so learned a lot. Walt Freed was the minority leader at the time, and he placed me on a organization that had just started that was looking into trying to get lower prescription drug prices. So I got to travel and talk with legislators from other states on what they were doing in healthcare and everything.
Nice.
And then the following year, Walt became the speaker, and he put me on Ways and Means. So I thought my days in healthcare were over with. But then Jim Douglas got elected, and named John Crowley to head BISHCA at the time.
Right, that's
And
right.
so he appointed me to fill John's seat in the Senate. And one of the first calls I got from him after that first session was, can you come to the office and talk? And they asked me if I would ask to be on health and welfare.
Wow.
And at the time, Peter Welch was the president pro tem. And so I went to Peter and I asked him, and he said gladly.
Yeah, that's great.
And so that's, you know, from there I got, because I was the only Republican on the committee, basically you're on health access oversight, mental health access oversight, all the special committees, the
Right.
Health Reform Commission. And so I spent a lot of time on healthcare issues, never thinking that I ever would.
Really? Use it again, eh?
Yep.
Here
And,
we are.
and in 2005, we were being pushed by the then chair, Jim Leddy, to pass a bill that I didn't like and I didn't vote for in the committee. And it ultimately was vetoed by Governor Douglas. But the following year we came back because if you remember back in those days, we had uninsured at 8%, and now we're down to 3%. And so in 2006, we came back and we ended up passing Catamount Health,
Oh,
which really made huge improvements.
right.
And so that was my history in healthcare.
Can I ask you about something about Catamount? I know we need to watch about the time, but if we had mandated that people be on that, do you think we'd have the same problems we have now if we actually mandated that people have to be on Catamount? Because what was happening was people were signing up when they were sick, would get the surgery, and then they'd drop off. I don't
And
think
an
we'd be
even
in such
bigger
a
problem
mess.
back in those days too, were the number of people that qualified for Medicaid but were too proud to take it.
Ah,
You know, and so
because I thought
I
that
thought
was a
that
good
Catamount
structure.
was a really good structure.
Yeah, I did too.
We had a slightly smaller reimbursement than commercial insurance for the employer-sponsored insurance plans that were available. And, you know, we were doing okay. And in some respects, I used to always say that I thought Vermont got penalized when the whole country started talking about
Yeah.
healthcare reform.
In
Right,
some
yeah,
ways,
right.
Catamount seemed better than the ACA.
Yeah, I think I wouldn't so much use the term better, but just two different approaches. And so Vermont had been out in front working on trying to make sure everybody was insured, but also doing creative things like the Blueprint for Health
Right.
Oh,
that I think we passed in 2006, started in 2007. And, you know, so we were already trying to create the nucleus for community-based teams that would coordinate care. And even then, we were talking about frequent flyers in the healthcare world, people that were constantly getting readmitted, whereas if they just had their care managed better,
Right.
they would stay out of that higher-priced hospital setting.
Yeah,
So
wow.
we were starting to make that progress, and then when the Affordable Care Act passed, we kind of had to do things a little bit differently.
Right.
So that's a good segue right into what created the Green Mountain Care Board. It really started, the foundations of it started with Blueprint for Health, and then you know, Act 48 in 2011, which is what created the Green Mountain Care Board.
Yep.
So
I was
tell
vice
us-
chair of the healthcare committee when that was being written.
so
Were you
you've
really?
become full circle
Yep.
now.
Yeah, right.
And I was the one who actually put in the triggers that I felt
okay.
protected Vermonters. So it had to meet certain actuarial values. It had to be, the revenue source had to be equitable. There were a whole bunch of different triggers. And it was done late at night. I was staying that year at the Hilltop Hotel. And I couldn't sleep because I knew that we were voting on it the next day. And at 3 o'clock, I got up and got my laptop out and saying, well, what if they would just agree to these conditions? And I typed those out and brought them in the next morning. And the majority of the committee was very, very supportive.
That's great.
And so was the administration, to my surprise at the time.
Yeah, now last time I remember when you were in the Senate, you were the chair of the Education Committee at the Senate.
Yep.
So when did you go to the Senate and?
So I went to the Senate in 2003, and I did chair the Education Committee at the same time that I was vice chair of the Health and Welfare Committee. Back then, Health and Welfare was a morning committee.
Oh, right,
and
the others after.
I remember John Campbell telling me how much trouble he was in with his caucus for giving me those 2 assignments.
Those are 2 pretty coveted positions.
Those are big.
Yeah.
But
And
just for our viewers, the senators typically serve on 2 committees. There's a morning committee and an afternoon committee.
And the House just does
and
one.
the House
Yep.
usually has 1 committee that
Yeah.
meets all throughout the day.
Correct.
And usually the morning committees have, I don't want to, fewer responsibilities than the afternoon committees because they usually have less time to meet.
Oh, is
Well,
that- is
plus
that
in the
sort of true?
Senate, those committees get shut down towards the end of the session, so that the money committees can really focus
Oh,
full-time
right. Well, that makes sense.
on the issues
Right.
that they're facing. So it's not to say that morning committees aren't important, because you have committees like transportation, that's a morning committee.
But they get their work
is-
done earlier in the session, and
Hopefully.
hopefully.
Senator Mazza gets sure it gets done.
I can
yeah.
tell you that I also was on Judiciary at one point, and Senator Sears never believed that a morning committee should shut down, and we were always working, and he would find strange hours for
Yeah.
us
You're
to.
I think he
Well,
still
he's
does
a
that.
worker, that's
I think he still does that.
He is a worker.
Yeah.
He
Senator
is a
Sears.
great
He
guy.
just, yep.
Yeah.
Puts his head down and just works. So how did you get to the Green Mountain? Because Al left at one point, and I mean, I must say, I had no idea you had this background. Because they said, all I remember was education. I'm like, what the heck is he doing?
The
But
committee that
you
I
got a great
chaired the
background.
longest was Economic Development.
Oh, that, I remember that.
Yep.
Right.
In the Senate,
And but the last year that I was there, I went back to the Education Committee, and
Right.
basically the Committee on Committees had told me I could go back to finance if I wanted to.
Right.
And there were so many problems in the education system, I just wanted to work on that
Yeah, right.
versus going back to finance.
Right.
When you're one of 7 on a finance committee, it can be pretty deflating at times.
Yeah. Versus
Right,
1 of 5 on the Ed committee.
Right.
Yeah, right.
Yeah.
Oh, really?
Yeah.
I didn't notice that.
Yeah.
Yep.
Huh.
Yeah, and actually, when I chaired the Education Committee, we were able to do things like limited school choice and things like that.
we like
So,
that.
you can make a difference.
Yeah.
You know.
Interesting.
Absolutely.
That's good.
But so, anyways, I ended up, you kind of know your internal clock tells you that it's time to
Time
go.
to go, yes.
And there were some issues coming down the pike that were going to be problematic. And I decided, I got a call. I typically take a vacation. This goes back to the years of running campaigns.
Yeah.
I typically take the week of Thanksgiving off and go on vacation. And I was on vacation. I got a call from a member of AARP and said, would you consider putting your name in the hat for what was then the Public Service Board?
Oh, ooh.
And I said, oh my goodness. I said, I just
No.
don't believe
Right.
that I'm the right person. And they had thought of me because of my work on finance, because I was questioning things that
Right.
were going on. And I said, I really appreciate that you called me and asked me, because it means a lot to me.
Right.
But I'm telling you that I'm going to be throwing my name in for a position, and I can't tell you what it is, but I think I could do more work in that position. And so what I didn't know, and I found out the very next day, was Al was named to be the secretary of the Agency of Human Services. And I was aware of another position that was going to be available there.
Ah,
So I put my name in, and it's similar to the Judicial Nominating Committee process. And I served on the Judicial Nominating
Right.
Committee for a number of years, so I'm very familiar with that process. And basically, you fill out, it's like a 40-page application, and put all your information out there. And it gets reviewed by an independent committee that's made up of appointees from the Speaker of the House, the President Pro Tem of the Senate, and gubernatorial appointees. So you go before this board, and they determine whether or not they believe that you're qualified for the position. And because there were multiple positions opened, I actually applied for just being a regular member or being the chair, assuming that I would most likely just be named a regular member. But as usual, healthcare surprises me.
Right.
And the session was going on, and I was chairing the Economic Development Committee, working very hard to get out a very large economic development bill. And I just assumed, well, the governor must not be interested because I've never gotten a call.
Right.
And then I got a call.
What?
And
You want me to do what?
What?
so,
That's
you know,
great, Kevin.
he asked if I was really sure that this is what I wanted to do. And I said, yeah, I think I could make more of a difference there than I can in the legislature.
Right.
And that's how it all came to be.
That's great, because seriously, we just talked before the show, and just doing the research and putting these questions together about what you've been doing, I had a headache. It's just huge, Kevin.
Having worked in a lot of public policy areas in Vermont and outside Vermont, the two most complicated policy areas to deal with are education and healthcare.
Healthcare, right?
And you've covered both of them.
Yes,
So
that's great.
clearly you're not afraid of either of those issues.
That's great.
But let's talk a little bit about the Green Mountain Care Board and what the main responsibilities are, what the role of the Green Mountain Care Board is. We kind of talked about you know, how you've gotten there, and a little bit about where we're going in healthcare policy in Vermont. But we'll talk more about that later.
Sure. So our mission has three primary goals. Obviously, the one most talked about is trying to contain the growth in costs.
Right.
But we're also, at the same time that we're charged with containing cost growth, we're also charged with making sure that everyone has access to quality care and that it's quality care. So quality and access have a price, and so you have to be very careful that you're not doing something to contain costs that would deny someone the ability to see a provider that they need to see. So that gets into the complexity of almost all the decisions that we're faced with. We, every hospital in the state, 14 of them, have to submit a budget at the beginning of the summer, which is another thing that is all wrong, in that the hardest work is during the summertime, so there's no way you could ever take a vacation in the summertime.
That's wrong. You have to work on that.
Yeah, because you have the qualified health plan rate reviews over the summer. You have the hospital budgets over the summer. It's just one thing after another.
Are hospitals calendar year or June to what is June?
Hospitals are October 1 to September 30th.
Like federal.
Yes.
Ah.
One of the things that would really make our life easier
Medicaid funding.
is if they were on a calendar year. And some of them say they can switch, and some of them say they can't switch, but unless they're all on that calendar year, because basically if they were on the calendar year, it would synchronize more our decisions on rate review and our decisions on the ACO budget.
Right.
But unfortunately, you know, we
Because
don't
the
have that
ACO
luxury
is
right now.
Operating on a calendar year,
They're operating on a calendar year.
and so are the insurance companies.
Well, it depends upon the plan, but primarily, yes.
Yeah.
And one of the things, you know, people are aware of our rate review of the QHP, the exchange product, but we also do large group plans as well. And we're starting to get those looking more on an annual basis. When I first came into the position, there could be changes every quarter. And, you know, that was just a little bit much to have to continually look at a plan that might have only, you know, 1,700 members.
Right. For the group plans.
Yeah.
Yeah.
What do you look at when, you know, they come in with their budget presentation? Do you have a list of things that you want them to show you? What do you use to judge whether you okay it or not?
So it's different depending on who we're analyzing. If it's the hospitals, we're very focused on their financial sheets.
Yeah.
So it's basically, we have two real levers when it comes to hospitals. One is that we approve their net patient revenue, which is their top line. But the other lever that doesn't get much press is we also are the ones who determine how much they can increase their charge master. So, for example, this past year, the press all focused on the fact that we allowed an NPR growth rate of 4.1, but the actual increase in charges was a little over 3%. It was 3.1. And the problem that we were seeing is that, in particular, UVM, very good at measuring what they're doing, and they were getting more and more unique patients, and it would be what I would consider economic development if these patients were coming from outside of the state into Vermont, but they were Vermonters. And we couldn't fully, and this is why I've had such a focus on trying to improve data in the time that I've been at the Green Mountain Care Board, we couldn't really pinpoint, exactly how many dollars were coming from, say, the Rutland Health Service area versus the Brattleboro Health Service area, and so on and so forth. So we're in charge of two large databases. One is the hospital discharge, and the other is the VCures. And so ideally, we would like to be in a world where all our decisions are based on strong data, but there are some delinquencies in that data. So one of the things that I'm charging the board members with going out and doing now is I guess it was about 3 years ago now, there was a Supreme Court decision that's known as the Gobet decision.
Really?
Yes.
All right, Al.
Yes. Unfortunately, we lost.
Oh, sorry, Al.
But Liberty Mutual won the decision, and companies that are ERISA plans no longer have to
ERISA's.
report information.
Right.
And one of the things that happened at the time was Blue Cross went out and talked to the companies that they were doing the coverage for, and 80% of them readily agreed to share their information. But other insurers in the state, and I'm not saying anything bad about them, but insurers like Cigna and Aetna, they did not do that same type of messaging to their clientele, and so they just kind of dropped off the radar, and we don't have all that data. So we have come up with a list of those companies that are not reporting now, and I'm asking each of the 5 members to take certain people and literally do a call on them to explain the benefits to everyone for having the data in the system so that good decisions can be made in the state of Vermont. So that's an exciting project that we're working on now, and we'll see how that comes out. So getting back to the hospital budgets, we kind of bifurcated it. When I first came on, everything was done at once, and one of the things is measuring quality, looking at what I would call the hospital report cards, the community health needs assessments.
Right.
And it got to the point where there was just too large of an area to cover at a budget hearing, and it didn't seem like we were putting the numbers out as much as we should to the people of the state of Vermont. So we've kind of bifurcated that process, and now the hearings that we have in August are more focused on the actual numbers in the budgets so that people can have that transparency and see what their local hospital is doing.
Right.
And in this past year, 6 of our 14 hospitals had negative operating margins. So there's a real problem in rural healthcare in America. Since 2010, 119 hospitals across the country have closed. Now, we haven't had any in that time period in Vermont, but we currently have Springfield Hospital in bankruptcy proceedings. And, our hope is that they never close and that the people of Springfield have that continued care, but there's no guarantee of that.
Oh, I hadn't actually heard that. That's kind of sad.
That is, they're in bankruptcy?
Yeah, I didn't hear that. How, just when you mentioned quality, how do you measure quality? Do you set performance goals for the hospitals? What measures quality, sorry.
So that's another problem that we have too, Pat, in
Sorry.
that, the federal government mandates these community needs assessments,
Right.
but not every hospital reports them uniformly. They have their own interpretation of what the question is.
Yep.
And in some respects, we get that same problem with some of the numbers questions, where one hospital may treat reserves one way and another hospital treats reserves another. And so we've been having meetings with CFOs at the hospitals trying to create a standard set of uniformity.
Right.
And as we talked about education, that was the same problem we had
I was gonna
in
say,
education.
It's the same problem
Well,
in education.
It's the same as state
common chart of
government. Ask
accounts.
how many
Yeah.
employees you have. You always get a different answer.
Exactly,
Yeah.
because
Right.
some
Yeah.
people are measuring it based on FTE,
Right,
some people are
exactly.
just giving you the total number, and you got to make sure that you're comparing apples to apples.
Exactly.
But we measure them on a number of standards, and that gets taken to the next level in the accountable care organization, because the all-payer model agreement that we signed with the federal government requires us to monitor 20 quality measurements. And basically these are measurements, there were a couple of areas where Vermont was not doing very well compared to the rest of the country. For the most part, healthcare in Vermont is better than the rest of the country. So when you hear people make statements about the U.S. infant mortality rate is high compared to the rest of the world, that's not Vermont. And usually we get ranked 1, 2, 3, or 4 in national rankings of the best healthcare states in the country. So, but now I'm starting to lose track of where I was headed here, Pat.
Well, we're just talking
Sorry.
about that.
So in terms of quality,
Yes,
you
that's
have-
where I was headed. I was
Yeah.
going to talk about those quality measures that are part of the all-payer model agreement. Vermont was not doing as well. We had more suicides per capita,
Yeah, that's been high.
and we had more overdoses per capita. So the third, even bigger pot that we're focused on in those quality measures is, we know that 20% of the population is 80% of the costs, and that's chronic illnesses.
Yep.
So things like diabetes and COPD and hypertension and things like that. And so the quality measures are basically put in there to measure how we're doing to try to get those goals in line. So we want fewer suicides, we want fewer overdoses, and we really want to see that people are getting better care for chronic illnesses. And I won't mention the name of the hospital, but one of the first hospitals that I did a road trip to as chair of the Green Mountain Care Board, the whole board did a road show, and they were so proud of their wound treatment center. And they were talking about all the legs they were saving from being amputated and blindness and things like that. And I asked the question to the doctor. I said, well, what are your primary care practices in your region doing to talk to people when they first measure high with their A1Cs and show up as a pre-diabetic and things like that, to try to get their diet and their exercise and things like that in order? And his eyes kind of glazed over. And so that's, where we used to be.
Prevention.
And we're trying to move away from that type of what I would call sick care to the minute that you start to show signs of being pre-diabetic, we want your primary care provider sitting down with you and saying, hey, look, here's the facts. And if you don't do something about it, you're going to face much worse outcomes in your health.
Yeah.
It's the old idiom, an ounce of prevention is worth a pound of cure, right?
Exactly.
And it's so true for both health outcomes, right? Their outcomes better the earlier intervene, but it's also really true for cost.
Yep.
It's much
cheaper.
much cheaper to treat and prevent an illness, or especially chronic illnesses, which you're saying, like you said, is 80% of the cost in the system. They're much cheaper to treat if you catch them earlier on.
Yep.
Yeah,
before they
we
progress.
did 8 opioid shows on training on addictional kinds of parts of the issue. And one of the shows we had 3 doctors on, one from Blue Cross Blue Shield, UVM, and they were telling us how they're treating the whole person now, as pretty much in line, like if massage works for you, or acupuncture, just different things, holistic things that really work and are not as expensive or.
And change is hard for people. There are
right.
some doctors who really don't want to change the way they practice, but the majority are really coming around to trying to focus on wellness.
Exactly.
And that's very, very encouraging to see.
Yeah.
So,
well, you mentioned earlier too the fact that we've increased our uninsured rate so much. Decreased. Sorry.
Yeah.
Decreased our uninsured rate. Increased our insured
worry
rate.
now is underinsured.
Right. Underinsured.
And that's what really is hurting, because a lot of people, it really gets down to affordability.
Yeah.
They just can't afford the products that are offered to them, and so they get high deductible plans, and then they bet that they don't need to go see a doctor
Right.
and things like that. And that's, what we would hope is that people actually had a relationship with a primary care provider and went and saw them, because over time, that is the cheaper way to go. And that's another area that we'll have to talk about at some point is there's a real workforce crisis in healthcare.
Right. Oh, we've heard that a lot from the Central Vermont, Washington County Mental Health. Mary Moulton's she's coming on the show, and they're robbing from each other because there's not enough.
There's not enough workforce.
Yeah, the hospital.
And it's not just nurses,
Right.
it's across the whole spectrum. And if you look at the most recent numbers coming from the Vermont Department of Health, we're not really making gains on getting more primary care. So other countries in the world that are seeing better health outcomes for less cost than the U.S.,
Right.
the basic difference is in those countries, there's 2 primary care doctors to every specialist. And in the United States, it's just the opposite. There are 2 specialists to every primary care doctor.
Interesting.
Yeah.
And you can understand, if you talk to a medical student, when you're saddled with $400,000 in debt, and you've got to make a decision what your career path is,
Right.
you're going to go where you can
Where the
pay
money
back
is.
that debt.
Specialists.
Right.
So,
Exactly.
Even people that, so for example, pediatricians who are primary care providers, a pediatrician student at UVM could be on that path. And then as they see their debt mount up, they could see that they could make more specializing in a certain
Right.
field of pediatrics. And so they go that route rather than just being a general pediatrician. And so we have to do more as a state. I truly believe that we need, and I don't have uniform convincing of my colleagues on the board or people in the healthcare community, but I truly believe that the only way we're going to solve this, because the whole country is facing a shortage, we're all getting older, is we need to have a program that basically is scholarship for service. We'll pay for you to go to med school, but
Right.
you've got to commit to whether it's 6 years or what have you,
Oh,
of
interesting.
being a doctor inside the borders of Vermont. And then I think,
It's like AmeriCorps for doctors
Yeah,
or
right.
something like that.
basically,
I bet it would work.
the trouble, and loan forgiveness has worked to take some of the edge off,
Yeah.
but it's an arms race. So you raise the amount that you're willing to
right,
forgive
right,
on loans, then the next state
Yeah,
raises
right.
theirs, and the next
Right,
state raises
right.
theirs.
Do you think the hospitalist approach has helped the GP doctor, general practitioner, to stay? Because I know my doctor, he just retired, but he wasn't even going to stay that long. But he said the hospital, the doctors in the hospital helped him because he doesn't want to work.
Yep.
You know,
So it's kind of a
24
mixed
hours.
bag, and it depends on which hospital you're talking about,
Right.
the success of that. I don't think that without the hospitalists, we would have a successful system of care in the state.
Interesting.
Because
It's not my favorite thing, but we won't chat about
no,
that.
I mean, in my perfect world, we would still have a whole lot of independent doctors.
Right.
But unfortunately, it's pretty hard to make a practice
Right.
go, and
No, I
it really
understand.
depends on where you are too. So if you're in Burlington and you have really good companies that are employers there that have good commercial insurance for their employees, your payer mix is different than, say, for example, a Springfield. So in Springfield, you have more government payers than commercial payers, and you're getting paid less.
Right.
So it all depends too on geography. So
even in Burlington, it seems like most of the practices that have been successful are the federally qualified practices, like the
What's that, Ben?
Burlington
I
Primary
the
Care,
federally
for
qualified
example.
health centers started years ago as a way to help impoverished rural areas
Oh.
keep
yeah.
care, and it's been expanded over the years. Bernie Sanders was a big proponent of
Yeah,
it.
he was one of the
Yes.
proposers,
Yeah,
sponsors of
I
legislation.
know what, yeah.
And basically, what you're seeing is that if you take where I live in the Rutland area, there are only a couple of doctors who aren't part of the FQHC.
Oh, interesting.
It's very hard to be an independent doctor because the FQHCs get reimbursed more.
Right. They get a higher reimbursement rate than a typical
Oh, really?
Yep.
doctor or hospital might get.
Because
from-
Rutland Hospital's done great, hasn't it? From what I hear, they're in good shape, aren't they, Rutland?
Well, they still have a positive margin,
Yeah.
but as I tell all my friends in Rutland, that their margin has been declining over time. Their expenses are growing faster than their revenues.
Yeah.
So they're
Well,
going
we
to
don't
be
have
in
enough people here,
the
right?
same
And they-
boat.
And they're also dependent on the whims of the federal government, whichever way stuff
Yep.
goes nationally, that can really impact those practices.
But Rutland, like the Northeast Kingdom and other areas of the state, like Bennington and others, they're older. And more you're seeing less quality employer-paid insurance. I mean, when I was growing
That's
up,
right.
there were General Electric, more Business Forms, TAM Brands, all these different manufacturers
right.
that really took outstanding care
Yeah.
of their employees. And you just don't have that same world anymore.
That's right, I forgot that. It's really bad out there in some places.
So, two other things we should talk about as part of the responsibilities of the Green Mountain Care Board. You also oversee the Certificate of Need process
Yep.
Yeah.
in Vermont, which is basically a methodology of reviewing capital expenditures by hospitals and other healthcare providers so that we don't build excess capacity.
Right.
Essentially, is the concept.
Yeah, when I first came to the board, there were even more applications because at that time, if a hospital wanted to replace their boiler, they would need to come
Yeah.
to us.
Whoa, we
And-
need a boiler.
Yeah, and nursing home acquisitions came to us. It was, and we didn't offer a lot of value because it's the licensing division at AHS that really is overseeing these nursing homes. We don't have their budgets. And it just seemed that there were areas that could be reduced on the CON level because what you want to do is make sure that you're protecting services. So for example, you might think it's a wonderful thing to have a private birthing center in a community. But say you're locating that in a Brattleboro or for as much as that goes, almost any hospital service area outside of Chittenden County. Births cost more than they take in. So they're losers for all the hospitals. So if you were to create a private birthing center with just midwives and not the doctors, midwives have to have a place that they can refer to immediately if something goes wrong.
Right.
So you would not want to approve something that could be large enough in scale that would make a hospital have to close their birthing unit because you still have those tougher cases that have to go someplace.
Right.
So those are the type of things that we should be focused on. The most expensive CON since I've been there was an IT project done by the University of Vermont called EPIC, $151 million.
Whoa.
Yeah.
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 We don't do IT projects too well in this state.
No,
Did
well, at
that
least
go
that
well?
one wasn't run by the state. That was
Yeah.
the UVM's project.
Yeah.
But
Yes.
Vermont, which is interesting, Vermont has, even though we've peeled back some of them,
Yep.
there's only one state that has more, and there's only, 20, there's a little over 20 and change that states that still have CON laws. And of those, Vermont has the second most restrictive. Only Hawaii has more categories that are covered.
Really interesting.
But I would say that at least in Vermont, you can tie it into other decisions that are being made by the regulatory body, which is in
Right.
this case the Green Mountain Care Board,
Yeah.
because of hospital budgets, because of charges, because of rate review and things like that. You kind of almost have to have your arms around all these things if
Yeah.
you're truly going to try to make a difference.
So, Kevin, can I just ask, we were focused on single payer when Shumlin was here, and that didn't go as planned perhaps. What are we calling it now? Is it this all-payer system, and what do we have, or we're not sure
So
yet?
it's called the all-payer model,
All-payer
and it's
model.
an agreement that was negotiated between Vermont and the federal government. And basically, even if single payer had gone through in Vermont,
Right,
it would not have impacted as many lives as the possibility that an all-payer model could affect, because it was never envisioned that the state's single-payer system could affect Medicare lives and try to do better care coordination for our elderly population. Whereas the all-payer model takes, in theory, all the different payers. So you're talking Medicare, Medicaid, commercial payers, and allows you to try to create that system of prevention and wellness for everyone and better coordination of care. And in fact, it's the Medicare population where you can save, in my mind, the most amount of dollars on, because it's not proportional. As you're older, as I'm beginning to find out,
yes,
you use more health care.
Yep.
And so if you can make sure that a local visiting nurse association is part of the discharge of the patient when they leave the hospital, then the home visits can occur to make sure that the patient is properly taking the medicine, is doing what they're supposed to be doing, so that they're not readmitted to the hospital.
Right.
So the all-payer model
Which is more expensive than the
much
home
more,
visits. Yeah.
much more expensive. And so the all-payer model envisioned trying to get everybody into this better coordinated system of care. And really, for years, the state of Vermont looked at Maryland, who was one of the first people to gravitate towards an all-payer type system. And they were always the ones looked on as like the gold standard for what you were doing to manage costs and improve care in a state. And so in 2015 and 2016, the state of Vermont, it was becoming pretty clear that Green Mountain Care was never going to be implemented
Which was single payer.
which was
Single
single
payer,
payer,
Yeah.
because you didn't have a number of the ERISA companies. Everybody says the money's already in the system, but a number of the ERISA companies were adamant that they didn't want, if I worked for their company in Burlington, Vermont, and another employee worked in Cleveland, Ohio, they didn't want different programs for them.
Right.
right.
And it was always problematic. ERISA laws are very set in stone at the federal level. Vermont was never going to get the ERISA plans.
Right.
So without the ERISA plans, without Medicare, where was Vermont really going to go? And at the time, they were projecting the possibility of upwards to 16% of a payroll tax, which was just a non-starter.
Really?
Right.
So it would be nice if we could reallocate the dollars that are already in the system, but the reality is it wasn't going to happen.
And Vermont already had some control over Medicaid funding anyway at that stage in the game. They just didn't have control over Medicare, which
Right,
is
they were already under a pilot program that
Right.
was working on savings for Medicaid.
right. So they had quite a bit of flexibility
Yeah.
Under the existing waiver before the all-payer waiver kind of came into the picture to play with some of those Medicaid funds, but that's still, even with the Medicaid funds and what was already in Catamount Health at that point, that's still less than half of all the funds involved in healthcare delivery.
Yep. And don't forget that because the exchange was created under the Affordable Care Act, Catamount was no longer.
Right.
So
did that wipe out Catamount? Is that why Catamount ended?
It superseded it.
Oh, did it?
Yeah.
Oh, I just always thought it was because people were going in and out, and we just didn't have the money to keep it going. Because I loved it. I thought it was great.
The healthcare exchange that was put in place by the ACA was basically filled the same market segment that Catamount Health was in.
And plus there was this large pool of dollars that was available from the federal government for basically premium credits, so that if I was making 200% of the poverty level, I could go on, fill out in all my information, and a large portion of my insurance was paid for with these credits.
Right.
And so it brought additional dollars into the system to help people become insured, but it really, we were getting there with Catamount. So it was just one of those things that, there's nothing wrong with the Affordable Care Act. I think the goals were very lofty, and that is the law of the land, so that's what we're living with. As a father, I was very grateful to be able to have a child still on a plan.
Yep. I have 2 grandchildren who are very thankful too.
Yeah, that was probably one of the most popular things.
Well, that one in pre-existing was
pre-existing and the 26-year-old.
Right. Yeah. Thank God for that.
Yeah.
So, with all those things working against the state of Vermont, the discussion started happening with Washington because Vermont had always looked at Maryland and was kind of jealous of what they were doing. And conversation started to gel with Washington because Washington wanted to try to start to move away from fee-for-service and try to get into a more coordinated system of care. And so even now you still have some doctors in the state of Vermont that make the argument that no doctor would ever make a decision based on the revenue that the decision make. But it's surprising when you get docs in a room, none of them admit to ever having a defensive medicine test or anything like that. But then you ask them the question, do you think your colleagues do? And they say yes. So in any event, the contract was negotiated with the federal government, and what had happened over time in Vermont, if you go back 25 years, healthcare was about 11% of our overall state economy.
Not now.
It was growing
Right.
and on the verge of hitting 20%.
Wow.
And we actually got over the 19% threshold. The last year that we actually have absolute data on is 2017. We're always behind a year. But in that year, we got down to 18.5%. And what was even more encouraging is Vermont had been running about 2.1 to 2.2% ahead of the other states as far as being a percentage of their GDP, and we got down to 1.5. So hopefully that's not a one-year blip.
Great.
Everybody says, well, do you even need a Green Mountain Care Board? And if you look at the numbers, even like hospital budgets, the what I would call the aughts, the 2000 to 2009, spending at hospitals was growing at an 8% per annum annual growth rate. 2010 through 2012, the legislature kind of put some restraints on where things could go for a few years, so they were held down. But then if you take a look at 2013 to 2020, we're always talking about a year ahead of ourselves, that growth rate is 3.9%. So it's half of what that growth rate was
in the 2000s.
Right.
So, we'd like to think that some of our decisions are helping to bend the cost curve, but then this year has been a very tough year. We had some huge rate requests that came in.
That we read about.
Yes, and when you're looking at 7.9% of that rate increase is just for a higher utilization of specialty drugs these are very expensive drugs that are used for
interesting.
things like cancer, leukemia,
Right.
those type of things. And they're working. So it's not like anybody wants
Hard
to be
to
a
say
death
no,
panel
right?
and say,
Right.
you can't have those
Right.
drugs. That would be the absolute wrong thing to do. It gets very hard because we can't control that. And we have conversations with our congressional delegation all the time, talking to them about what we're seeing.
Right.
Peter Welch has a bill in now. I don't know if it'll go anywhere, but I hope it does. Donald Trump, when he ran for office,
talked about that,
was
right?
very clear that he wanted to try to
Right.
bring down prescription drug costs.
Right.
And so I think that he's on board. If you take a look at what he announced, I guess it was about a month ago now, with transparency, in 2 years, it's not just going to be the charges that are going to be available from hospitals, but it's going to be what you actually pay
Right.
across the whole country.
Right.
Yep.
And that is one of the things that I think will really help to bring down healthcare costs.
Well, the state auditor has talked about that too. That healthcare price transparency is a big deal, because you can go, hospitals right up the street from each other can have dramatically different sticker prices for something.
I remember arguing, I'm not going to say with who, but when I was in the Department of Labor, it's hard to get to know what that item costs in healthcare. The tongue depressors, I said to him, how much does a box of tongue depressors cost? He said, I can't tell you. I said, why not? We argued back and forth.
A simple
And
dose of aspirin.
Well, because he said it depends on which surgery it's used in.
Yeah.
I said, but it's a tongue depressor. It
It's so
depresses
crazy.
your tongue.
It's-
And he said, yes, but if it's used in a kid's tonsillitis, it's one number, and if it's used in a heart transplant, it's another number. I went, I don't want to hear this. So
We were
I
looking
shook
at,
my head.
I believe it was a heart ultrasound just this morning at a meeting that I was in, and the differential was tenfold depending on where you got it done
Right.
Yeah.
in
there
the state
you
of
go.
Vermont.
Right.
Yeah.
And, I recognize, and I'm sure the two of you recognize, that a hospital like a UVM or a Dartmouth should get a little bit more, because they're paying for all these medical
Right,
students to
right.
be educated.
Right, the
And so
teaching
you want
hospital.
those tertiary hospitals to get a little bit more of a
Right.
reimbursement. But where does that line get drawn?
Right.
And that's one of the things that is tough. And you want to see more pay parity, because you don't want people getting the same care at a higher cost.
Right.
Or you don't want people penalized, because there's certain things that you can have elective. Like if you're having knee replacement, you can decide where you get
I wish
that.
you hadn't used that
Yeah,
example.
he just giving me.
My
his
knee is
knee
killing me.
bothering
Sorry.
Think of something back.
Anyway, an elective procedure, right? You can shop around a little bit for that. You can call up UVM, you can call up Dartmouth, you can call up Rutland Regional and be like, how much is this surgery going to cost me? If you have a heart attack, you don't really get to make that decision.
No, you
You're
don't.
going to the nearest hospital.
Exactly.
Whatever.
And you shouldn't be penalized because the nearest hospital to you happens to be the most expensive. Right?
Right, for
That's
sure.
that's what you want to prevent from happening.
Yep.
Not that you're thinking about that at the time, right? Just
No,
fix
you're
it.
not.
Who cares?
Yeah, but you don't want to be penalized because what you have access to happens to be the most expensive option or a more expensive option.
Yep.
So before we run out of time, we've all been reading about OneCare.
Yep.
And could you explain to us what it is we are reading
Well,
about
Sure.
OneCare is the ACO.
It's an accountable care organization, and the federal government created incentives for care to be coordinated by what they called accountable care organizations. And at one time in Vermont, we thought that we might have three. So there was OneCare, there was the VCO, Vermont Care, and then there was SHAC, which was the Community Health Centers organization.
Yeah?
But the only one that got to the finish line was OneCare. And people ask me all the time, don't you wish there was more than one accountable care organization? And my answer is it's kind of mixed, because I'm a big believer in competition, so I do think it's good
Right.
to have competition. On the flip side of that, if you had two accountable care organizations or three, they each would have to have their own administration, their own IT, and everything else. So it's a mixed blessing. I think at the end of the day, I still would err on competition being good, but we don't have that luxury. So we're dealing with the one accountable care
And what does that
organization.
mean to me as a patient? And do I know I'm in a one care situation? I mean,
So-
my doctor just retired and I went to another doctor. And do I know if he's a one care doctor or do I care?
So I don't think, despite everything that you read lately in the press,
Right.
that you really need to have a fear about being an attributed life. If anything, you should get better care by being an attributed life because you're being measured and everything else. And your health outcomes are going to be what that practitioner is being measured by.
Oh, and paid by?
So, yes, exactly.
Oh.
And so,
That's good.
would you know? Yes. What would happen? I think it's, let me get this order right. If you're new, you only get this letter once, but say that you've recently become an attributed life, you would get a letter from, I believe it's Medicare in January telling you that you're now an attributed life. Medicaid's letters go out in February telling you you're an attributed life, and the private insurers would go out in April.
Good grief.
And this is based
Yeah.
on who your primary care physician is, what bucket you would be in, like which group you belong to. And basically, and what you mean by attributed life is the way that the ACOs work. The accountable care organizations are part of this all-payer waiver, which instead of reimbursing based off of procedures, like the actual procedure, you'd be reimbursed based on keeping a population healthy. So the population, you being part
So
of the
if I
population,
get better, he gets more money?
would be attributed to that ACO
That's cool.
population.
I like that.
So getting back to, because this all ties into One Care too, what the model looked at was the rate of growth in Vermont's economy over the previous decade and a half, and that had been about 3.5% per year when you average it out over time. And so the theory was that the growth in healthcare spending had to be kept at or below the growth of the economy, otherwise it wasn't sustainable. So that's where the 3.5% growth targets came from. And then in addition to that, Vermont has to be 0.2% below the national trend for Medicare. Because remember, Vermont now has access
Right,
to these Medicare
right.
lives, and the federal government wants to see that there's some cost containment there as well. But at the end of the day, the overall Vermont population, everybody, all of us, even those that aren't an attributed life,
Right.
that growth rate has to be 3.5% or less.
Interesting.
And it's a 5-year agreement that expires in 2022. So that's the big goal, besides all the quality measures, is to be able to keep the growth of costs growing at less than the growth of the state economy.
That's a great way to end this discussion. Our hour is up. You have got to come back. I've got way more questions.
Yeah, there's lots more we
So,
can talk
listen,
about.
Kevin, we really thank you for coming on. You were a perfect
it was a lot of
person to
fun.
be a chair.
Thank you so much.
Thank you.
Thank you very much for tuning in. We'll have Kevin back because I have way too many questions. Anyway, we'll see you next week. And in the meantime, keep listening beyond the sound bites.